Hello, everyone. We are presenting a case of unrecognized cardiac sarcoid leading to catastrophic syncope. Um, Cardiac sarcoid is a potential life-threatening disease with a variable manifestation ranging from subclinical disease to sudden cardiac death. We are presenting a case of cardiac sarcoid which went unrecognized until a catastrophic syncope helped to clinch the diagnosis. Our case is a 44-year-old female who actually worked as a nurse in our OBGYN floor who presented with a multiple episode of syncope and pre-syncope few days before this presentation, along with a dyspnea. Her past medical history was significant for splenomegaly, for which she underwent a splenectomy 5 months prior to the presentation. And the pathology from splenectomy showed non-satiating granuloma without any evidence of malignancy. A follow-up CAT scan after splenectomy was performed for CT chest and CT abdomen did not show any evidence of lymphadenopathy or any abnormal pathology. On the day of presentation, patient presented with a syncope where she actually passed out for a few minutes, which was a witness event. Upon presentation to the emergency room, her initially blood work included complete blood count, chemistry, thyroid panel, Lyme serology, and autoimmune workup were unremarkable. Cardiac troponin I was mildly elevated at 0.056 ng per ml, and electrocardiogram showed complete heart block with an escape rhythm at 30 beats per minute. There was no evidence of ventricular arrhythmias. Left heart catheterization was performed on urgent basis from the emergency room, shows no significant coronary artery disease. Echocardiogram shows left ventricular ejection fraction of 30-35% without any significant valvular abnormalities. In the light of non-satiating granuloma seen on splenic pathology with complete heart block and LV systolic dysfunction, cardiac sarcoid was considered the likely diagnosis. Cardiac biopsy was not performed given that patient had a prior splenic biopsy results. Steroid and later methotrexate was started, and patient underwent placement of biventricular implantable cardioverter defibrillator. There was no evidence of pulmonary, neurological, or ophthalmological sarcoid involvement. A few weeks into treatment with the immunosuppressive medication, the patient had resolution of complete heart block. Earliest available PET scan was 2 months after diagnosis, and start of the treatment did not show any evidence of systemic sarcoid, and her left ventricular ejection fraction was reported to be normal on the PET scan. The device interrogation also showed complete resolution of complete heart block with the patient back into normal sinus rhythm. In the discussion section, cardiac sarcoid is a serious manifestation of sarcoidosis. It can remain asymptomatic, or it can present as a conduction abnormality or as a heart failure in terms of a variable manifestation. The presentation can be life-threatening, like in our patient. Cardiac sarcoid can occur up to 20% patient with the systemic sarcoidosis. Up to 25% patient can have isolated cardiac sarcoid. A timely clinical diagnosis was made and a treatment instituted without waiting for diagnostic PET scan or cardiac histopathology helped us to save the patient from another fatal outcome. In conclusion, we're presenting a patient with a nearly fatal cardiac sarcoid that went unrecognized for a month after her pathology when she was found to have non-satiating granuloma. The rest of the workup as an outpatient did not show any other findings, and no further workup was pursued. And patient was having still episode of syncope and pre-syncope. So early recognition of cardiac sarcoid therefore is critical to prevent life-threatening consequences. Thank you.